All right, I'll go ahead and get started. Other people may join in as we move along, but that's okay. I know your time is valuable. I'm excited to discuss Standard Imaging's Adaptivo EPID dosimetry software today. This software is specifically designed to help clinics manage the higher level of risk associated with modern treatment techniques these days. With Adaptivo's real-time in vivo modules, clinicians will be able to better identify and adapt to issues regarding either patient setup variations or, more importantly, anatomical changes. So overall, they'll be able to ensure and improve the quality of treatments from beginning to end of a patient's treatment. So before we begin, there are a few housekeeping notes from our team. Today's webinar will be recorded. You will receive a link to the recording, but you can find access to this and all the previous webinar recordings on our website at www.standardimaging.com. For those of you who aren't familiar with Standard Imaging, we are based in Middleton, Wisconsin. We were founded in 1989, and we design and manufacture a full suite of QA products for radiation therapy, both hardware and software. Please enter any questions into Teams anytime during the presentation, and I will do my best at the end to get to all your questions. So Adaptivo is a patient dosimetry solution developed by Standard Imaging that uses your existing EPID technology to its full potential. This solution offers automated patient QA and risk management tools that monitor, assess, and assure quality of care for each fraction of a patient's treatment course. The tools are designed to be easy to use and can be seamlessly integrated into any clinical workflow. With automated patient dosimetry verification, healthcare providers can guarantee that the quality of care is maintained throughout the treatment process. And this is becoming more and more important as the trend towards dose escalation and hypofractionation in radiation therapy is really driving this need for real-time quality assurance for every treatment session. Adaptivo provides 3 modules that can fully automate your patient-specific QA, including pre-treatment QA, as well as daily 2D in vivo QA, and we also offer a daily 3D adaptive module, which can be used in certain cases. Today, I will provide a high-level overview of the different algorithms implemented in each module of Adaptivo, along with industry data that emphasizes the importance of in vivo EPID QA practices becoming a standard part of every patient's treatment journey. Additionally, I will review clinical examples for both our 2D in vivo module and our 3D adaptive module. So the Adaptivo EPID dosimetry solution really is a useful tool for managing the increased risks that we're seeing in advanced radiation oncology treatment these days. Again, highly conformal treatments, doses are higher, fractionation is shorter. So we need to be able to react to deviations to really manage the risks that we see now. Automating the risk management process throughout a patient's treatment is now recommended as it plays a crucial role in preventing errors. The data out there is showing this. A 2021 article on human factor associations with safety events showed that QA errors are prominent in the field of radiation therapy and can lead to severe consequences. The article highlights the importance of establishing departmental funding for safety tools that balance the ever-growing complexity of treatments and technology in our field. I know from my time in the clinic, both as a physics supervisor and a department manager, things happened and good people can make mistakes. Smart people can make mistakes. And even when you have all sorts of checklists and training in place, there is a human factor, and that's something that really needs to be considered and try to automate these processes to reduce that human factor. The International Atomic Energy Association has also published a report stating that the use of in vivo dosimetry systems could have prevented a series of serious accidents in radiation therapy. The report also highlights that the cost of implementing in vivo dosimetry programs is justified by the prevention of severe consequences resulting from such errors. So now really, as physicists, we truly need to get the support of our administrators to help us with automating these practices. Our plates are full in the clinic as a physicist, and we too are humans. So if we can automate some of these tools and find efficient ways to alert ourselves of any deviations, that is a step in the right direction for sure. Many modern oncology clinics offer advanced treatments, but they still rely on the subjective QA practices that I mentioned. These practices include, daily cone beam CT review by physicians, which often have to happen on the fly. They may need to interrupt a consult they're in and come and review and quickly make a decision so the patient can proceed with their treatment while they're laying on the table waiting for this to happen. And weekly chart checks by physicists are often too delayed. That only happens once a week. So the patient could have received 5 fractions that were suboptimal. However, there really is a growing need for real-time, automated, and quantifiable in vivo QA tools that can immediately alert clinicians and physicists when a dosimetry discrepancy occurs. And this really ensures, proper mitigation steps can be taken in a timely manner. So my question for clinical physicists, as well as physicians and department administrators, is why aren't you using your existing EPID technology to mitigate these risks and improve quality by expanding patient-specific QA throughout the entire course of a patient's treatment? Why do we stop with pre-treatment QA? Modern EPID technology boasts superior image quality and improved dosimetric characteristics compared to EPID technology of the past. Moreover, EPIDs are superior to traditional detector devices such as diode or ionization chamber arrays because they offer higher resolution, better efficiency, and really greater ease of use. It can be seamlessly integrated into almost any treatment workflow, allowing proactive monitoring of dose during treatment delivery, rather than some of the reactive steps that we are forced to take in our clinics today. And this enables immediate detection of errors or discrepancies and will really facilitate quick adaptation to setup issues or even adaptive planning evaluation due to anatomical changes. So now that I've really hammered out the whys of Adaptivo EPID dosimetry, I'm going to take a moment to give a quick overview of the hows. If you tuned into Shannon Holmes' TG307 overview webinar 2 weeks ago that I also participated in, you'll likely recognize this slide. At the time, we didn't go over too much the details of Adaptivo in relation to this, so I'm going to dive a little deeper into that today. There are 2 categories of EPID dosimetry. We have non-transit and transit dosimetry, and each of these can be associated with either forward projection or back projection computation techniques. So to review a little, non-transit dosimetry does not include the patient or a phantom. It's what we know as some EPID pre-treatment QA. The EPID panel is directly exposed to the unperturbed treatment beam. And this result can be evaluated as a forward projected result, meaning at the EPID panel itself, or it could also be evaluated as a back projected result where the EPID data is projected in air back to the level of the isocenter of the beam. Adaptivo's pretreatment module uses the non-transit forward projection technique. Now, the column on the right represents an in vivo transit dosimetry setup where EPID panel measurements are acquired during a patient's treatment, and the exit dose is measured at the level of the EPID panel. Adaptivo's 2D in vivo module uses the forward projection approach, where dose measurements are compared to the treatment planning system plan or a reference treatment image at the level of the EPID panel. Conversely, Adaptivo's 3D adaptive module utilizes the transit dosimetry back projection technique. So in this case, the EPID data is projected back into either the planning CT or CBCT for dose computation and comparison to the treatment plan. So as I mentioned, Adaptivo really can be easily integrated into any clinical workflow. As I mentioned, we offered 3 modules, which enable a comprehensive automated end-to-end patient QA solution. This diagram demonstrates how Adaptivo's automation fits seamlessly into your clinic from your pre-treatment workflow, where you can see here it's very similar to any pre-treatment workflow. However, the QA, it's much easier to complete this QA because it can be easily done by your therapist. And any failures would just revisit the planning system or kind of loop back around for that QA process. Now, both the 2D in vivo QA and the 3D adaptive modules can give non-conformance warnings that will trigger risk assessments. So those images and the analysis can happen on a daily basis when everything is good to go. The physicist doesn't get any alerts. Treatment just continues as usual. But when there is a non-conformance warning, the system can be set up to alert the physicists via email as well as right within the software itself. And this is a great tool to trigger risk assessments at this point. So likely the very first place physicists will start is there a setup or machine delivery problem? So that will kind of be that first workflow. Perhaps the patient wasn't in their immobilization device correctly. Maybe it was the wrong immobilization device. Those things happen, and Adaptivo would catch that, and you'd be able to quickly mitigate that issue before multiple fractions went forward with that wrong setup. Now, of course, as treatment progresses, we, in some cases, hope that patient anatomy changes, especially tumor size, and Adaptivo will stay in tune with that and be able to alert and allow clinicians to start their adaptive assessment hopefully earlier on than they would from the traditional subjective approach. So in this case, the physician and physicist could be easily triggered to review and make more informed decisions about whether the patient needs a re-CT and need replanning for their adaptive treatments. So really, to truly understand, the quantitative power of Adaptivo, I'm going to quickly present 2 real-life cases where Adaptivo was helpful in determining the need for adaptive therapy measures. Here we have a lung case. The image on the left shows a CBCT image with the original planning CT structure set overlaid on it. We can see that there have been some changes in the patient anatomy since planning. This includes fluid clearing from the lungs. We see some tumor regression, as well as it appears the patient has lost some weight. But what isn't clear from this image is the dosimetric impact of these changes. And of course, the traditional subjective CBCT review by the physician may also overlook the fact that these changes may significantly affect the dose to the tumor or surrounding critical structures. So on the right, there's a little snippet of some of the 2D gamma comparisons results for this particular patient. So each column represents a different fraction, and each row is an analysis for an individual beam. So this is showing fractions 31 to 37. And as you can see, beams 1 through 3 look great. 4 was kind of giving us a warning. So the colors and the numbers shown at the bottom of each square is the quantitative value of your gamma analysis, and the colors would be your alerts, pass warning, failure. So green, yellow, red. So It looks like somewhere along the way, probably around, this fraction here, things did shift to a point where the other three were in a warning and the fourth beam was in a red. So something is happening within this patient. So this is, if these four weren't already a trigger to keep an eye on things, suddenly seeing changes in all four beams, which would very likely have a significant impact on the overall dose to the tumor and critical structures, this would trigger a more in-depth look at what's going on here. So within Adaptivo, the 2D module, you can look at trending of the gamma analysis over time. So here, each column is representing an average for the week. So this is week 1, 2, 3, 4, 5. So week 5, we started seeing something happen. That's where we're seeing some of the yellow alerts. Week 6, it's trending down, although on average, it's not looking bad. But if you look at this trend, it's really a very good early indicator that this is a patient that you need to keep an eye on. And as it progressed more, you can see things trended off more and more. So in this particular case, the patient went back for a new CT and a new adaptive plan was constructed. Here's a closer view of what the individual field gamma results look like in terms of display. So we have hot, cold gamma that can be displayed over the DRR, and then we have a hot, cold gamma over your treatment portal as well. So as you can see here, there's hotter areas due to changes in patient anatomy, which is very likely due to a combination of all three of the things we saw: tumor regression, fluid was gone, and weight loss. So those three would have an additive effect on the dosimetry. This next case I'm going to show is again evaluated using the adaptive module, although this is the 3D module. The 3D module is very good for head and neck cases. As is common, the patient lost weight during treatment and the mask was fitting very poorly. So daily setup started to become inconsistent. The effects of these changes are tracked in Adaptivo. In the lower left, you can see a graph showing decreasing target volume as a function of the delivered fractions. And there are significant dose differences between the planned and cumulative delivered dose, which can be viewed in the dose difference map in the upper lower right. The lower right corner shows DVH differences between planned and delivered cumulative dose. And again, in this case, Adaptivo provided the information needed by the physician to make an informed treatment decision. So that it really helps with the early triggers for adaptive therapies, so you can make sure that your quality of dose delivery is optimized throughout the entire course of treatment.